Everyone ready to go out and get an ICL done?
How often like, do you ever actually do these?
So in fact, I have not done this since fellowship. If that answers your question about my level of interest or comfort with this technology.
But is that because people don't want it, or
it's not because people don't want it. Frankly, to give a personal aspect on this, and I know that Dr. Kanellopoulos is probably on the call here, and I know that he does this technology a lot. I just don't find a role for it in my patient practice. I don't have enough patients who need it, and the potential complications I think are not worth embarking on from my perspective. But I know that a lot of surgeons do use this quite a lot, and I think that surgeons who are higher volume in this technology will have a much better success rate and a much lower complication rate than somebody like me who would do it occasionally. So I think that people who are higher volume refractive surgeons will be able to use this technology successfully. Dr. Kanellopoulos, did I approach that politically okay?
Oh, that's a good comment, Jonathan. Thanks so much for including in this discussion. I enjoyed your presentation very much. For me, the turning point, and you mentioned it in using the ICL, was the centriflow hole. And it's interesting that my friend Tobias Neuhan from Munich for 15 years now has been punching that hole in ICLs on his own. This idea took about 10 years to be embraced by technology. And the key thing with the centriflow hole in the ICL is that, number one, you don't have to do a laser iridotomy, which is always not a good thing, in my opinion, and a very high myope. Number two, it tends, since aqueous flows through it, to hold the lens a little further away from the crystalline lens. As far as its use, I'll share with you my personal practice. I'm going more and more in the ICL on myopes that are over 8 to 9 diopters. In the whole of Germany, ophthalmologists have come together and have agreed that no laser surgery on the cornea is done for myopias of 8 diopters and over. So there, the great options that you mentioned are the rule for higher myopias. We know that in the US and throughout the world, laser correction has approval for some lasers up to -14. But considering the optics of very high myope, the fact that most high myopes, in my opinion and experience, get early cataract formation, probably in the late 50s, early 60s, and the window of opportunity of them to have good quality of vision, I would discuss it with any patient that is over 7 diopters as a means of it leaving after its removal, when the cataract evolves, the eye with better optics than if you had changed the cornea surface dramatically. So in my practice, I do a 1 ICL for every 10 laser procedures on the cornea.
Thank you, John. I'm going to take this opportunity to shift the talk over to you, if that's all right. Okay. And I'm going to sit in and listen. Please enjoy your talks, but thanks for joining us today, of course.
Oh, sure. Fantastic.
JK, just one last question I had was regarding the lens vault. Is it a minimum of a half corneal thickness, or a minimum, was it the 550 microns minimum that we're looking for?
John, do you want to take that question?
Well, we're looking at anything that's comfortable for the surgeon. We ideally want a volt that's over 150 microns, because this assures that there's no contact between the ICL and the surface of the crystalline lens. But again, like everything in life and in surgery, the bigger the volt you desire, sometimes you may end up having a volt that's 500 microns, and then your lens is uncomfortably sitting high in the anterior chamber. In my experience, and I've not done hundreds of these, I've probably done close to 100. We've only had one case that the calculation of the lens diameter did not work out well, and the lens was sitting very flat in a lady, and it did aid in an anterior capsular cataract. And the little pearl here is that in some of those very high myopes that abuse, for obvious reasons, contact lens use, the limbal architecture sometimes is a little bit difficult to define, both for the clinician and for devices that measure white to white, because for someone who wears for 20 years lenses 18 hours a day, there is some opacity developing in the margin of the cornea, and that may throw off the measurements a little bit. So the ideal volt for me would be somewhere between 150 and 200 microns. So correct half a cornea thickness, roughly.
Thank you.
It's kind of similar if you guys have experience with scleral lenses. It's kind of a similar distance, same distance that you want the scleral lens from the apex of the cornea, 100, 150 microns. You want to see a similar picture on anterior segment OCT with the ICL.
Mm-hmm. Thanks, John. I'm going to turn over the talk to you.
Okay.
And thanks everyone for coming in this morning.
Thank you, Jonathan. Excellent talk. Really enjoyed it. All right. So good morning, everybody. It's early or Friday evening for us here in Athens. It's really a pleasure to be with you guys. We have two options, and we discussed this. We can run through some videos of the three most common cornea-based refractive procedures, PRK, LASIK, and SMILE, and then talk about a review of potential complications to their management, or do this vice versa. It's up to you guys. Which one you want to do first? Want to go through the video, the procedures, maybe first?
Videos
talk
first.
Complications. Videos first. Okay.
I think the videos first would be most helpful.
Okay, videos. I'm going to share my screen. Okay. So are you, do you all have my screen in your monitor?
Yes, we do.
I'm going to start with PRK. Okay. Let me see. Need to get this to play. Try and play this with QuickTime Player. Okay. All right. So we'll start with PRK, and through this video, I will share with you. Is everybody seeing the video screen?
Yes.
Yeah. Yes.
Okay, great. All right. So this is a classic LaserVision evaluation. The Optos has been great looking at peripheral fundus exam. We're picking up one tear in every 100 young myopes that we're screening. And for me, this is a pivotal step of deciding whether I'm going to advise for a young myope, young meaning anybody younger than me, younger than 55, to have LASIK or PRK, because that's always the question that comes up. What's best, LASIK or PRK? And you will obviously create, as you move along and do both of these procedures, your preference. But it's always puzzling to choose between the two. This is an anterior segment OCT map of the cornea, and it is, and we've reported extensively on this, a little bit more accurate in measuring cornea thickness. We're seeing that map on the left, which is a total cornea thickness map. Thickness is not bad. Minimal thickness is 500 microns, as we can see here. So for many LASIK surgeons, this would be a good area to do LASIK if we're talking about a -6, for instance. What I don't like here is the epithelial maps. the epithelial maps show a tendency of them being thinner in the center, thicker in the periphery, and the family has some children with strong keratoconus suspicion on sine fluke imaging, meaning your pentacam. So I'm trying to paint the picture here why we chose PRK. This is the other eye, and we can see the same flavor, minimum corneal thickness 503 on the OCT. And again, the epithelial thickness, and these are now the pentacams, where again, the astigmatism, not a strong astigmatism, but there's certain truncation of the astigmatism. Let me go a click back on the first eye, the right eye, because this for me is an important finding. You can see that the cornea is steep, goes flatter, 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 but this gradient in cornea curvature is a little bit steep, and the astigmatism is certainly truncated. Do we all understand what truncated means? The bow tie, the astigmatism is narrower than the 9mm diameter we're seeing on the pentacam. The bow tie is here quite narrow. It's down to 3mm in length. And then if we go at the thickness maps with the pentacam, you see that these maps are not in gradients that are circles and centered in the center of the eye. They're a little bit oval that tend to skew temporally, and there's more steps than the classic 2 steps we see in cornea thicknesses. So this again for me is a little bit tricky. The backside of the cornea again is not very symmetric. The front side of the cornea, as you can see, has the apex a little bit off center, but this could be due to angle kappa. And when you're evaluating your pentacams, your angle kappa is down left where it says pupil center. It has the pachymeter measurement at the pupillary center, that's 527 microns. And then the X represents the deviation between the cornea vertex to the pupillary center. So theoretically, that's the angle kappa. And it's very little. It's just 80 microns on the x-axis and just 10 microns on the y-axis. So here, if we want to beat this to death, in my opinion, we're seeing a very, very tiny keratoconus that has never blossomed. But, you know, this may sound extreme. This is the other eye, a little bit smoother, more centered apex. And then we're going to see more of the diagnostics. You can see the underlining of the truncation here on the placido disc imaging of the cornea and the other eye. So our decision, this being a lady close to 40, mild myopia, this is a new technology that combines wavefront sine fluke imaging and action length measurement. It's called ray tracing, quite complicated, but it kind of gives you a good estimate of the refractive error. We'll talk about this maybe some other time extensively, and I always do interferometry in order to confirm that the myopia in patients is axial, and it's not due to, for instance, spherophakia, because in a patient with spherophakia that shows false myopia, you don't want to do cornea-based laser surgery. So this kind of sets the record that this is axial myopia. Pupilometry, we've reported on using your pentacam pupil. And this is our flow sheet. It's still in paper. We want to track who is filling out the numbers. So one eye minus 4.5, the other minus 2.5. So relatively medium to mild myopia. And these are all the technical data that are used in order to choose the images that the Innovise software, that is the software that does ray tracing, uses to come up with the refraction. And you can see here that subjective is a minus 4.5. The ray tracing software comes up with a minus 511, 019, and 32. I'm not going to go into why and what are the advantages in choosing this customized platform, but we're going to continue seeing the other eye numbers. And on the laser, you can obviously, most lasers, you choose your optical zone. Some lasers, you can choose the transition zone, a key element of reducing spherical aberration. And we're going to talk about spherical aberrations in our complications section post cornea-based laser refractive surgery. And you always want to confirm data. Unfortunately, I've seen many times treating the right eye with left eye data, or treating a patient with another patient's data. So it's quite crucial to do all this confirmation, just like you do in your cataract surgery. Timeout, come in the laser room, do a 5-second timeout, confirm patient's name, age, birth date, with the numbers you have on both screens. Remember that patients are in shock. Any questions that you will answer them, they'll say yes. So don't rely on what patients say. You can ask your patient in the laser room, is your name John Kanellopoulos? They'll say yes. So remember, that's not a very objective way of confirming patient and data. These technologies, fortunately, do not go forward if they don't recognize the pupillary architecture they have done in the diagnostics. So that's an indigenous safety measure to treat the correct data on the patient. And obviously, you want to do all this confirmation algorithm before the patient is in the room, especially in your first cases. You don't want to be doing this with the patient under the laser head, because that will just increase anxiety. We can see here is a typical Greek patient. There's a lot of eyelid and eye movement. I like to drape with Tagaderm stickers the eyelids. We've brushed the eyelids with a swab stick with betadine. Used a drop of moxifloxacin before we begin. Just so I make the disclosure, I do consult for Alcon, but I do want to share with you that all lasers, both used in the US and internationally, are very close to each other in accuracy and efficacy. So I'm going to try and be as much as commercial bias free here. So draping the eyelids is also a good test to see if the patient will comply with the procedure. Obviously, PRK is very easy. And here we'll see another technology that's not new. It's used in the US for a couple of years. It's called EBK or ORCA. It's a plastic, non-sharp instrument that is used to remove the epithelium. So you just rub it over the dry cornea surface. The novelty here that we presented the last 2 years in meetings is that I'm going to try and do a very small de-epithelialization, the smallest possible to fit my ablation. It's a little tricky because this device is a little bulky in order to be very accurate in removing small amounts of central epithelium. And obviously the purpose here is to have the patient reepithelialized. We found that invariably all patients have reepithelialized by day 3, which is a paradigm change for PRK. So we've called this mini-PRK. The tricky thing here, if you're removing the epithelium manually, and this holds true with using diluted alcohol as well, is you have to make sure that you're seeing the shiny Bowman's surface all around, and there's no little island of epithelium left behind. If the patient had a sterile corneal ulcer from the contact lenses in the past, they may have a patch of epithelium that doesn't want to come off easily, and you do not want to leave that behind, because once the laser ablates the stroma, it's going to leave a patch of untreated area. So here we have, you can see here again that I've only cleared an ovoid of about 6.5 or 7 millimeters diameter vertically, and about 7 millimeters horizontally. And this, we'll see during the laser procedure, will be sufficient to fit my ablation. The laser here is a flying spot laser at 500 hertz. So treating the first eye, which if I remember well was a -4.5, will take under 6 seconds. And this is real time, and you can see the laser spots. You can also appreciate a very important part in excimer laser evolution is that the spots do never hit the same spot again. They kind of travel across the surface of the cornea in a random order. And this is done in order to avoid having the next spot laser through the ablated tissue plume that comes off the cornea. So thus increasing the efficacy and the homogeneity of the laser ablation. So you can see now my ablation, we said it was a 6.5 diameter OZ with a 1.5 TZ. Breaking here with some lasers helps, and there's various reports on this, reducing post-PRK haze. because you're allowing the cornea to cool down, and also make sure that the surface is homogeneous. We're applying here mitomycin C, 0.2% or 0.02 milligrams per ml. We're based in a southern European country. We have sunshine almost 365 days a year. So it's common to have to deal with cornea haze after PRK, thus the precaution with mitomycin. Rinse, I'm sure you're all familiar with this, even from glaucoma procedures. Rinse very carefully with chilled BSS. This is the most unfavorable part of the procedure. And then start topical drops. We found a game changer, Bronfenac. Commercially, it's Prolensa in the US, it's Yellux in Europe. We have a little bit of a higher concentration in Europe. It seems to have made the trick for these eyes to be completely painless the first night, taking away one of the major disadvantages of PRK. And please interrupt me if you have any questions in the technique. A bandaged lens that has been also soaked in Bronfenac while we were performing the procedure in that eye. So sit on the cornea and act also as a sponge that will release Bronfenac, and obviously steroid and a fluoroquinolone, and we're done. The beauty here of having such a small area of epithelium deepithelialized, not using a transepithelial approach, some excimer lasers give you the option to remove the epithelium with the excimer laser, is that this lady is going to stand up from the laser bed and is going to have 20/20 vision. And it's going to be she's going to be relatively comfortable the first night. No pain meds, certainly, and I strongly discourage this because many clinicians are using it, giving patients diluted topical anesthetics. And we'll see a disaster case later on that. They get low fuzzy between day 2, somewhere between day 1 and day 2 when the cornea reepithelializes in the center. And of course, we explained this beforehand. But this approach has made PRK more similar to the lamellar refractive procedures, LASIK and SMILE. And we'll go to the other eye, which is pretty much same theme. I'm going to fly through this. Again, just show you the small area that's deepithelialized, and caution that you want to make sure that this area will fit your ablation. You do not want to leave intact epithelium at an area that the laser will ablate, because then you'll have irregular ablation. So this takes a little bit of experience. And obviously, if you're going to start with this in your first PRK case, try and go halfway of deepithelializing the whole cornea or the small area that I have done here. You want to make sure that you're not lasering through even a small island of intact epithelium. So this is the mini-PRK technique. Most eyes, this is on day 3, believe it or not. Lenses off, cornea reepithelialized, not 20/20 yet, but 20/25. They reach the 20/20 at the week interval, day 6 or 7. And of course, here in Southern Europe, we really work on agents that reduce haze, such as vitamin C, 1,000 milligrams per os per day for 2 months. Strict use of glasses, real sunglasses that hug the eye, not glasses that are there as a fashion statement, and a cap for a full 2 months in order to avoid haze, even in light myopic cases. And this is an image of this patient on day 3 or day 4, and you can see the complete. I want to go back to the cornea epithelium map, because we use these to assess epithelial healing, and you can see that right at the border of my deepithelialization and the ablation, there's still an area that needs to remodel, but the cornea has reepithelialized nicely. It has a area here that's thicker, and by observing cornea epithelial maps, you can assess quality of vision and level of dryness very accurately, and correlate the patient's symptoms and sometimes complaints postoperatively with the imagery that you have on the cornea. This is amazing technology. We've had it available for the last 12 years now, and we've reported most of the body of the literature on using epithelial maps derived by anterior segment OCT back then and 10 years ago. So, and our pentacam maps, we're using them to confirm the centration of the ablation, et cetera, et cetera. And this is what you get with most excimer lasers today, a very uniform, very broad ablation. Some of the old problems with halos and night vision problems, even in mesopic conditions, came because the older broad beam lasers had an effective optical zone of treatment, 4.5 millimeters. Here we're seeing on the pentacam that we're over 6 millimeters. Don't think that this ablation is decentered because it's centered on the cornea vertex automatically by the laser. That's why there's a little bit of a discrepancy on the cornea thickness and the effective ablation zone that you're seeing. So that's mini-PRK. Any questions on PRK?
John, can I ask you a quick question about the mini-PRK
Sure.
technique? And we're using this technique as well in our mini-PRKs, but I'm always curious about what happens at the border zone, because, you know, let's say that our that our ablation is set for 6 millimeters and has a blend zone that extends a little bit outward. What happens to the scanning slit ablations that happen right at that border where some of the ablation may catch the edge of the epithelium that still exists?
Well, obviously that will alter your transition zone. It will make it a little bit steeper. So it's nice if you know the total optical zone designed by the excimer laser to kind of go a little bit further out with your ABK device. The good thing with the ABK device is that the borders of the deepithelialization tend to have steps in the periphery from going from Bowman's to a very thin layer of the basal epithelium, then thicker and thicker. And this is why these eyes, the theory behind why these eyes epithelialize so fast afterwards. We've not seen any problems with irregularity in the optical zone. But my anxiety is always, and you bring up a very good point, Jonathan, thank you. My anxiety lies always with whether I'm going to miss an island of epithelium somewhere here, and this will leave an irregularity in ablation. But if I go to the borders of my deepithelialization, this border here is not sharp. It's kind of a set of stairs that come down from the epithelial surface down to the basal layer and Bowman's. And you want to make sure that you have enough space to fit your ablation, and including your transition zone. That's a good point. Because otherwise you're narrowing your transition zone, and you're number one, having a narrow or no transition zone will encourage the epithelium to remodel and regress your myopic correction. Number two, you'll have more spherical aberrations and night vision problems. So this is one of the things you want to avoid.
Thank you.
Sure, good question. I will go to LASIK. I've chosen LASIK Extra not because I'm a strong believer of this being a routine procedure. And I remember Dr. Khan receiving the best resident paper at the ASCRS for presenting LASIK Extra and hyperopes. This is many, many years ago. But because we had the opportunity of having a tremendous Italian film guy from Milan, and we're getting very good captures. And I want to stop and go in these captures to share with you some of the points of LASIK that I think are very important in the everyday LASIK practice. Now, this is the refractive suite by Alcon, but as I mentioned, most excimer lasers today are excellent and over and above what you can wish or what we used 20 or 25 years ago. Here, this is the femtosecond laser. Obviously, in LASIK, you need to use two devices. You need to create a flap, either with a mechanical microkeratome or a femtosecond laser. Here, we're seeing the parameters that we're designing the LASIK flap. You have the ability to design the flap diameter, the flap depth, the transition edges of the flap. I just reviewed a paper of 40,000 cases from Italy, and how many of those were avulsed or moved by trauma. Don't get scared. Only 9 of 40,000 patients, and none had a significant visual sequela afterwards. But femtos came to the limelight initially because you can design a more vertical edge of the flap than your microkeraton, which comes in quite smooth and thus is more prone to epithelial ingrowth and or sliding and or having the flap avulsed or moved. So obviously we're timing out here again, confirming patient data. One thing in Greece in particular, I think it's the same thing in Italy and Spain, is some young adults have first cousins that have the exact same name and very similar birth dates. So you have to be very careful. We've done, I can remember the same day, 2 first cousins that had the exact date and they had like a month birth data apart. So I don't want to sound an overkill, the safety feature, but I have seen it many times using wrong data on the wrong patient or transposing axes in laser vision correction. And I've worked with a team in Chicago recently in trying to fix that. It's a little bit of a headache. Here, we're showing that in this particular laser, the patient interface, and most excimer lasers use a disposable patient interface, comes calibrated for the factory. And this particular femtosecond laser, this is the FS200. I think it is the most popular in the US right now. That and the Zemer recalibrates one, it sets into the laser. Again, very important here, I'm trying to show you that the orientation of the head, this holds true in your cataract surgery as well. I'm sure that your cataract surgery mentors will spend a lot of time with you on making the patient comfortable, bringing the patient's head in a horizontal position so you in your surgical field will not be operating on a tilt. You can see here, and plus this is uncomfortable for this young lady because her neck is stretched out. So I have the ability to raise the headrest and number one, make her or move it, make her more comfortable and bring the surface of the cornea in a more horizontal position. I'm going to tilt her head leftward so I can remove the nose from my field. I don't want the nose to push on the patient interface and give me improper applanation and suction. So these are measurements you need to do and adjustments beforehand. Some patients tend, through anxiety, to move. Many patients tend to crawl into the fetal position, so bring their chin down. In our first surgeries, we tend to push a lot downwards, thus moving the cornea plane sometimes behind the palpebral plane. For most people, the cornea is over the opened eyelids. That's another important thing when we start doing intraocular surgery. Again, the tegaderm draping of the eyelids that, as I mentioned before, LASIK began as an in-office, a very nonchalant procedure, and we've encountered back in the 90s some tremendous catastrophic complications with infections, et cetera, et cetera. And we have to remember it is a procedure. Some people will argue whether it's an intraocular procedure or a surface procedure. Here, very important point for femtosecond laser, see how I'm going to leave a crescent of sclera that's more wide superiorly than it is inferiorly, because I'm going to try and bring the hinge. This will make a superior hinge, this femtosecond laser. I'm going to try and bring the hinge of the flap further up, so the clear space after the flap is lifted is centered to the pupil. And we'll see this when we lift the flap. This is a little bit pearl. I'm moving in, and I'm exaggerating here, the PI to make sure that I'm pushing on conjunctiva about 360 degrees. You want to be tilted when you place your patient interface because you may have incomplete suction. You want to make sure that you're pushing onto the conj to have it sponge on the conj. Now my patient interface is applanating on the surface of the cornea, and it's very similar in SMILE as well. The difference in SMILE is that the VisuMax has a curved patient interface, and there's less applanation. patients feel less and there's less suction, so patients do have vision throughout the procedure. And this is why I chose this video. We can see side views, and what's important here, I'm going to track back a little bit, is you want to make sure, and this is when we start doing procedures with colleagues, is you want to make sure that your speculum is under the patient interface. Obviously, there's pressure going in from the device to the patient's cornea. We always have an assistant check the position of the nose and the patient interface. We don't want this patient interface to be pushing on the nose because this will give incomplete applanation. And now here we're confirming the position that the femtosecond laser is going to carve, if I can use the term, the flap. See that since I'm displacing my hinge a little bit superiorly, my pupil is centered to the distance that is going to be left open in stroma after I lift my flap. So I'm not centering this circle to the pupil because my hinge is going to encompass in the clear area that I can ablate. It kind of matches what we talked about before on the area that you want to deepithelialize. So my plan for femto flap is a little bit decentered superiorly, and this is the lamellar cut of the flap. I've come to use 110 microns as my gold standard the last 10 years, and then a quick side cut. This was real time, so it takes just 6 seconds for this femtosecond laser to perform the flap formation. Check on the time, we're ready at half hour, and we're seeing some side view images. So femto part is over. We're going to do the same thing in the other eye. I'm going to speed track this, and then the patient is going to be moved. It's quite nice if you have a swivel bed to move from the femto to the excimer. The Zemer laser actually swivels into the bed under the excimer laser. So there's a lot of ergonomics involved in for the surgeon, for the patient to be the most comfortable in LASIK procedures. So this is the tracking device for the excimer laser. I use a disposable cannula as my sole instrument that comes in contact with the patient's cornea. And we'll talk a little bit in the next session of complications. Why is that? I do not want to reuse any instrument that will come in contact with the cornea or the cornea stroma. So this is a sterile, disposable irrigation cannula that at this point of the procedure, I'm using it as a forceps rather as a curved spatula to lift the flap. And I want to go back. In femtosecond laser flaps, the flap is not created, it's separated. So there's still micro adhesions between your flap and the cornea. And it's almost impossible to start separating from the open side of the flap to the hinge. It's always more practical to start at the hinge, because now you have resistance from the rest of the flap, allowing you to dig in here, push towards the hinge, and then release the flap the other way. So I'm releasing the flap, the last adhesions from the vertical cut of the flap. I like to always fold the flap onto itself. Some hungry, I guess, colleagues call it echoing the flap. The reason I'm doing this is because I'm reducing the chance that any particles that may be present in the laser room will land on an open flap that's been placed upside down and just hanging open. Number one. Number two, I'm reducing the amount of dehydration that my flap will have during my excimer ablation. Now, this is a very crucial point for those of you who will endeavor in cornea-based laser refractive surgery, because once you reach this point, everything in the laser room has to be ready. This is not the time, once you lift the flap, to stop wondering, is this John Kanellopoulos under the laser? What was his myopia? Oh, -6. And then the patient says, well, doctor, I thought I was a -5. And then you start making all this conversation and you're adjusting your laser numbers, and you leave the cornea like this for 5 minutes. Once you lift the flap, you should all hear somewhere in your head a ticking clock that ticks dehydration. So if you leave the cornea 5 minutes as so, you may end up with a underlying cornea. If a flap was 110 and the cornea thickness was 550, you have about 460 microns centrally in the cornea. If you stay like this for 5 minutes, those 460 microns may turn out to be 400 microns. And thus your ablation will have a much stronger kick than what you have planned for. So very important, and this is a crucial part for beginning LASIK surgeons, to, before the patient enters into the room, make sure that you're familiar with how the excimer laser works. You sit there, you know what button, if the pedal is set for your foot to press on, if you're going to do it with or without your surgical shoes, if your team is ready with the numbers, et cetera, et cetera. So here, the next step should be your technician will say, you're ready, I'm zooming in my excimer laser, and this is the excimer working in action. And you want to make sure you're not staying close to this with your spear sponge, because your spear sponge may actually block some of the ablation. That's an important part. Hands off when this happens. You can see the tracker tracking on the right hand of the screen. And in this particular case, we used riboflavin to perform LASIK extra, but that's not important. The important part is that once we finish the soaking, let me go back to this point. Okay, so we finished the soaking with riboflavin, and now we're going to close the flap very carefully. We're going to rinse carefully the flap and reposition the flap in place. I use a bandage contact lens in LASIK eyes as well, and this is my technique of repositioning the flap in place. Besides some surgeons liking to mark the area that's going to include the flap and the residual cornea, so thus those markings will match after the flap is repositioned, I like to use a suspension steroid, and I'll show you why. It will delineate the flap gutter. I will use a Johnston applanator. This is a lens, a very broad lens of 30 diopters in curvature, so it's flatter than all corneas, to push centrally on the flap and thus push away all the little wrinkles that the flap may have. Because remember, if you're treating -6, -7 myopia, you're going to remove part of the stroma in a lenticular fashion, and then you're going to have the flap come over it, and the flap will just fall into that little pit, and it may wrinkle. By using the Johnston applanator, you're moving, or you're hoping you're moving some of those wrinkles towards the periphery of the cornea where they don't have any visual effect. So again, I want to show you some close-up views of how we're rinsing the flap. Again, remember my cornea plane is over the speculum. I'm not pushing towards the eye, because then the eye has a lot of spring motion. You can push it way under the speculum level and be having all this stuff within your surgical field and making your life difficult. And excimer ablation here in a side view. And again, I'm going to go into the rinsing part and how I thoroughly use now my disposable spatula that I talked about before. That's essentially an irrigation cannula. See how that cannula is curved? Actually, this particular one is designed by Peter Hirsch of New Jersey. And how I'm using the suspension steroid, not just for anti-inflammatory purposes, but to delineate the gutter and give me the definition that my flap is sitting exactly where it should be. If my gutter is thinner on one side and thicker on the other side, that tells me that my flap has landed skewed towards the thinner gutter side. And if my bottom gutter, so the gutter that's at the free end of the flap, is very thick, that means that I have fluid somewhere in the flap holding the flap up. And I do not want to leave that flap that way, because I'm going to end up with striae in the flap. So I use the Johnston applanator. This is something that not many surgeons use. And you can see here very nicely how the gutter of my flap is delineated all the way around, and it's homogeneous. So this is my pearl of fitting flaps in the perfect position. And then have the patient come up, stand up, and watch the clock on the wall, smile. That's what we all work for. And we're all done. So that is a typical LASIK procedure for me. We've posted many of these on our YouTube channel from our LaserVision Eye Center here in Athens, so you're welcome to watch many of these procedures on our YouTube channel, besides the small palette we've created here with procedures. We'll take a few LASIK questions if you have, and we'll finish our cornea-based laser surgery with a smile case. I'm not sure everybody's online. Okay. Can everybody
yes,
hear me?
yes, yeah.
Okay.
Thanks for
Great.
reviewing PRK and LASIK with us. That was really great.
Sure. You're welcome. How do I, Thanos, how do I enlarge the screen of All right, so we'll finish our venue here, our trip through laser cornea vision correction with SMILE. SMILE is relatively new. It's not a new procedure, but it's gaining fans and among clinicians as well, because it has some intrinsic advantages over PRK and LASIK. We'll go over them while we're seeing the procedure. As a preparation and execution is very similar to LASIK as far as the use of the femtosecond laser. Its only intrinsic difference and maybe difficulty is fishing out that lenticule from a 60-degree SMILE incision in the periphery of the lamellar cut. And that's the only tricky part. For a good anterior segment surgeon, it has a very short learning curve. Just a few cases, but there's a few steps that you need to follow in order to avoid hardship with this procedure. So we'll go through our usual nomogram. I hope you're seeing what I'm seeing on the screen. This is a case from the study that we published. We have 3 peer-reviewed articles on this, comparing one eye SMILE, one eye LASIK. And in essence, we found that both procedures were excellent in correcting myopic and myopic astigmatic refractive error. And again, the same theme here, evaluating the corneas with all modalities. See how the astigmatism in this eye is not truncated. See how the bow tie goes almost from one side of the pentacam map to the other. Pentacam sees only the central 9 millimeters of the cornea. The back side of the cornea has a few colors. We have angle kappa here, 350 microns on the x-axis, 270 on the y-axis, so significant angle kappa. Again, axial length measurements to document that the myopia in this patient is axial myopia, and then pupilometry to make sure that our ablation or our planned ablation zone will address most of the mesopic pupil demands of the patient. Although in my personal opinion, matching scotopic pupil size with ablation was more of a problem when our lasers were not centering very well. So having halos and spherical aberration at night is not that much a mismatch between ablation zone and scotopic pupil diameter. It's rather more of the laser delivery not being very well centered on the cornea vertex. But that's a different discussion. It's very esoteric for cornea surgeons. So this is the only device that until now can do the SMILE procedure is Zeiss's VisionMax femtosecond laser. It's a femtosecond laser that can be used for LASIK procedures as well, just to create flaps. This is how the interface looks like. And we are planning the cap data. Cap in SMILE language is the thickness of the cornea that it's going to left behind on the top of the procedure. And the manufacturer recommends that the cap is 130 microns. So we followed this to the letter. So all our caps in the study were 130 or planned to be 130 microns thick. And then the femtosecond laser by default will carve a 15 micron non-refractive lenticule just to give some bulk on the lenticule that will be created and for the surgeon to be able to manipulate it. So a priori, 15 microns of cornea tissue will be removed. The recommendation is that you treat myopia over 3 diopters, so that 15 microns of central cornea in the lenticule plus the amount that's calculated by the Marmelin formula for the 3 diopters of myopia and up will add up to a lenticule that's going to be close to 50 microns in thickness and over eventually. So the cap is being defined by a lamellar non-refractive cut. And then the actual refractive part of the lenticule is the deeper cut that's curved and has a refractive aim. The deeper, obviously, cut is performed first, so we don't have to go through the superficial cut bubbles. And then the surface cut and the side cut is performed second. So this is basically SMILE in a nutshell. We'll go here and watch a real-time procedure. Again, this is the patient. One of the comfortable things with SMILE is that the patients don't black out because the suction from the VisionMax excimer laser, femtosecond laser rather, remains within the 30-35 millimeters of mercury that are not enough to close the ophthalmic artery. And thus the patients can continue to focus into their green light that'll be blinking during the procedure and retain a, we hope, dynamic concentration onto the centration of the excimer laser. You can always judge a patient anxiety on how they essentially almost jump at the use of extra topical anesthetic and antibiotic. And we're going to rinse the surface because we want to remove any particles that will go between the patient interface and the cornea, the surface of the cornea. But we want the cornea to be relatively on the dry side. We don't want to use lubricants because if they go between the patient interface and the cornea, they will reduce the thickness planned with a femtosecond laser because they will increase the distance of the patient interface to the desired location. So we're letting the surface to dry a little bit, and this is a little bit of art. I'm going to jump the gun here and do it manually with a dry Wexel sponge. And then what you're seeing here is the PI engaging. I can't see anything here. This is the surgeon's view. I only see the green blinking light that's going to be the focusing reticule for the patient, and also my guide through the first Purkinje image to center my femto laser correction onto the cornea vertex. So again, I'm not going to center in the pupillary center. I'm going to center on the vertex. Thus, the area that green blinking light will be seen on the cornea surface. I'm almost applanating. You'll see me touch the cornea in just a few seconds. Very slowly, talking to the patient, have them focusing on the green light, coming a little bit closer, and we'll see me touching the cornea now. So you see the area being applanated, and I'm going to use the Purkinje image, the first Purkinje image of the fixation light as my guide. We're not seeing here in this video well the pupillary aperture. And this is the first refractive cut that's performed deep in the cornea. And now my superficial lamellar cut that's going to define that from the cap is a little bit broader. You saw it goes almost 1.5 millimeters more to the periphery. And now the superior SMILE, we had a vertical cut down here. Let me bring this image a little bit higher. So a 60-degree cut. So in SMILE, we have almost the exact opposite of LASIK. Instead of leaving 60 degrees of uncut cornea to create a hinge, we leave all the lamellar cut uncut, and we just define a vertical cut at 60 degrees through which we're going to try and do a tiny cesarean and remove the lenticule. So that's the applanation and the femto working. Let me see, we have about 10 minutes left. And Now we're going to have the Vision Max remove the PI. We'll focus through the device onto the cornea. The patient, as I mentioned before, has remained with vision. Patient did not black out. We can see here clearly the refractive cut, that's a curved cut, deeper in the cornea, I should say, and the lamellar cut, that's a planar cut at 130 microns depth, and the vertical incision of 60 degrees at the edge of the lamellar cut. And now the tricky thing is to be able to delineate the lenticule and pull it out with a leadable manipulation. So this is the only tricky part. And in essence, what we're going to try and do is use the special instrument on one side of our smile incision and define the area that's between the lamellar non-refractive part. So I'm first clearing the microadhesions on the smile incision. And then I'm going to use the same instrument that's basically blunt, go in and then push upwards and define the area that's between the lamellar cut and the residual cap of the smile procedure. So I want to have a clear separation between the space between the lamellar cup and under the cap. And that I'm doing on one side of my smile incision. And then I'm going to use the other side of the smile incision to do the opposite, to create a space between the refractive cut, the deeper cut. So now I'm going to point towards inside, deeper into the cornea, and you can kind of see the lenticule edge here. I'm not sure you're getting much clarity on here, but you can kind of see the edge of the lenticule define itself here as I'm going under the lenticule and creating the space here. So now I have two different pockets, one pocket over the lenticule and one pocket under the lenticule. And it's very important to first separate the lenticule in the anterior pocket. And this is a lesson you learn very vividly if you do it vice versa, because it's very difficult to separate the lenticule from the cap. So you want to first separate the lenticule if you had done the refractive separation first. And see here that with this olive tip instrument, I'm pushing all the way to the edge of the lamellar cut in order to make sure that my lenticule refractive cut will be definitely free of adhesion. So I'm defining the full space of the lamellar cut, and now 360 degrees, and now I'm going to use the same instrument to go under the lenticule. And you can see the edge of the lenticule here and go straight to the end and then start separating the sides of the lenticule almost symmetrically, because I want to separate the bottom part of the lenticule coming up and make sure that I'm keeping the side superior adhesions, because otherwise the lenticule may shrivel and get stuck somewhere on the bottom of the pocket, and it'll be very difficult to get out. So I slowly free the lenticule throughout, and I'm confident here that I've released adhesions 360 degrees. So I'm going to use a toothless forceps to pick out the lenticule, and I'm done. So the beauty with the smile procedure is that this is it. We don't lift anything. We don't have any excimer ablation. The inside of the cornea is not exposed to the air of the laser room. I'm pushing up the residual fluid, and the procedure is essentially done. The vision after procedure, because you have two lamellar and refractive cuts with a femto, is at the 2030, 2050 level. The first day they're at the 2025 level, and the first week they reach similar levels with LASIK. So there is a little bit of a slower wow effect with SMILE. I'm going to go to the other eye of that same patient, if I have it, to just, actually this, the other eye of that same patient was treated with LASIK, and we saw that before. So I'm gonna run back and let's see again the removal of the lenticule, because I think that's the most important part in SMILE. The rest is just computer logistics. So once we're done with the femto I'm going to watch this in real time. We're going to break the microadhesions at the smile incision. And we're going to use this blunt spatula to define the space, the superior space of the lenticule between the lenticule and the cap, and then go the other side of our smile incision and define the space between the lenticule and the residual stroma behind it. So we want to have these two different pockets created before we start manipulating the space that's under the cap. So then first separate the lamellar non-refractive cut, so the superior cut with this olive tip spatula. Very careful not to tear my smile. You need to see how we're careful in swiveling the olive tip instrument, not pulling it side by side, because your cap is 130 microns and you can tear its sides and go from 60 degrees to 90 and 100 and 150 degrees. It's very easy to tear the edges of the smile incision. So I'm making sure that my space over the lenticule is clear, all the way around and all the way to its edge. And now I'm under the lenticule. I go all the way to the bottom. And now symmetrically, I swivel left and right, coming up towards my smile incision, not releasing my lenticule from one side because I will not have traction to release the other side. So now I'm releasing completely the lenticule from one side. I'm pushing it within the pocket and bunching it up on the other side, and it's almost completely free. This is the part where if our adhesions are not fully released, by pulling the lenticule, you can leave a little piece behind, and that will not go well with the refractive effect that you are desiring to get with a smile procedure. Same thing if you don't clear the space as we showed, you can get some resistance in removing the lenticule and leave a little piece behind. By the way, in a smile procedure, if something goes wrong, you can always go back to the femtosecond laser, enlarge your side cut, and convert the smile procedure into a LASIK procedure. So that's a little bit of a safety feature in smile. Before you manipulate the lenticule, you can still convert it into a LASIK procedure because you have the lamellar cut and so on and so forth. So this is a brief review of a smile procedure. And this concludes our journey through the three major laser vision correction procedures on the cornea.
Dr. Kanellopoulos, you had mentioned
Yes.
at the beginning of your talk that you tend to prefer phakic intraocular lenses for high myopia, but Dr. JK had talked to us about the fact that in Europe it is indicated or at least approved for higher orders of myopia. What makes smile less attractive for you in higher orders of myopia compared to intraocular IOLs?
It's a very good question, and thanks for bringing it up. I'm moving more and more towards using a phakic IOL in lower, so to speak, myopias, meaning people who are over 8 diopters. I started using it in people who are over 12 diopters of myopia. The reason being is that in my personal practice here, I don't know how things are. I'm always forgetting what it is to deal with high myopes in the US, especially in female patients who are over 6 diopters myopic. They're invariably going to get cataracts, significant cataracts, around their 50s. 50 to 60 is the age that they will have cataract surgery. So now I'm fast forwarding a -8 myope who we treated at 35, 15 years later, that now has a cataract. And by the way, remember that some of these cataracts will first reveal themselves as increasing residual myopia. So this is where you have to go back to your interferometer and confirm that it is actually the lens that it's their crystalline lens that's thickening and not their cornea that is steepening, and they're losing the myopic effect you achieved with your LASIK procedure. So if we go now at 50 years of age and we're performing a cataract procedure in and I'm going to say young lady because I'm seeing almost 3-to-1 keratogenesis in females versus males with high myopia, you have to deal with some very distorted cornea optics. Besides the fact that you're going to use an aspheric intraocular lens, still these patients will have poor quality of vision at night. All myopes that are over -8 do not have the same visual performance after LASIK with myopes that are -3. And they know this, and in my opinion, they don't complain about this because that's the same way they see at night with their contact lenses and their career of being contact lens users prior to our laser vision correction. So if you put on the table, as now a cataract surgeon, what would I prefer to have? A virgin cornea or a cornea that I've corrected 11 diopters of myopia? Of course, I would prefer for the logistics of the improved optics of that patient, the virgin cornea. So for the rest of their lives, they're going to have a much higher quality of vision with the lenses we have today. They may have tremendous visual performance. That's one. Number two, phakic IOLs, because they're closer to the nidal point of the eye, magnify. So by default, you have an extra line gained in their visual correction because of magnification. So that can cover up some of the nomogram issues with the ICL. It is clear that the ICL is not as accurate in correcting refractive error as our lasers are today. So even if you're half a diopter off or 3/4 of a diopter off, or your astigmatism correction is a little bit off, it's forgiving through the magnification effect of the ICL. So it's mainly, number one, quality of vision. They have much better quality of vision. Number two, looking ahead of these patients in the, well, relatively near future, undergoing cataract surgery. And if we're talking about female patients, a much gentler, transient, and maybe permanent dry eye profile after a 270-degree vertical cut with a LASIK flap versus a 2.75 incision at the limbus to place the ICL in the eye. And the worst thing that you get within the ICL, because it's far away from the cornea, and if you manipulate the lens with some expertise, it sits behind the iris. The worst case scenario is that they'll develop cataract earlier. And I do discuss this with patients. I tell them that you have a propensity with your high myopia to get earlier cataracts. There's a 2 or 3 reported incidents of anterior capsular keratogenesis, rather subcapsular keratogenesis with the ICL. If we put the lens in, we'll never know whether your cataract will form due to your high myopia or our ICL. But even if that comes in as a late mishap, again, you remove the ICL. It's the easiest thing to take out of the eye, and then perform your cataract surgery, and again, bring the patient into whatever state you want, a metropic or slightly myopic if you're playing with monovision. And you're able to give them better quality of vision, one. Number two, if you're pursuant of multifocal IOLs, forget about using a multifocal IOL in a patient who had LASIK for a -8 diopters of myopia and over. That's a bad combination. And a virgin cornea, you can certainly entertain that possibility.
I have a question. This is Carl. We talked a lot about myopia, and laser correction for myopia, intraocular or phakic IOLs for myopia. But what about hyperopia? Is there like a max hyperopia that that you would do, and would you ever do? Do they have phakic IOLs for hyperopia?
Great questions, Carl. Thanks for asking. For us here in Greece, which is unusual for my New York city practice, is I see almost one hypero per every 4 myopes. it seems like hyperopia is quite more common in the Greek population than it is in the average patient that I see in the US. Yes, in hyperopes, we do employ LASIK. I have changed my standard there as well. I used to perform a hyperopic LASIK all the way up to -6, which is actually the FDA approval level, and the level for most excimer lasers that they can reach up to +6. Now I've moved more to a +3 to +4 as my max. The reason being, again, the significant manipulation in the corneal optics, plus the fact that usually hyperopic patients are patients in their 50s. We usually see hyperopes at age between 42 and 60. So then if I have a hyperope who's a +5, number one, and remember this guy, make sure the angles are not very narrow. You don't want that patient to leave your exam room and get angle closure across the street. Always evaluate angles in hyperopic patients, and discuss the possibility of, instead of, for a +5 52-year-old, instead of doing a cornea-based procedure, to perform a cataract procedure or clear lens extraction, or however you want to call it. Now, in the rare occasion, because usually hyperopic eyes have very shallow chambers, that your chamber will be over 2.8 millimeters, you have the option, it's available internationally outside the US, to use a ICL for those patients as well. So there is an ICL available for hyperopic patients, taking that they have a deep chamber, which is a rarity. So you do have the option to do that as well. I'm not a big fan of that, because we all know that in hyperopic patients, the chamber will get shallower much quicker than in myopic patients. But that's definitely an option. So to sum up, I will treat hyperopes up to a +3 with either PRK or LASIK. SMILE is evolving into bringing an FDA-approved technique that you'll be able to do a hyperopic SMILE as well. It's being used outside of Europe. It's not approved in Europe yet, but I know it's used in Asia, India, and other parts of Asia as well. And hyperopia is another area of interest. You can get a very good LASIK or PRK result in a hyperope taken that they follow the traditional hyperopic tradition that their corneas are flat. You do not want to be performing hyperopic laser vision corrections in eyes that have keratometries over 45, because then you're turning these corneas into very steep corneas into over oblate corneas, which also creates issues with quality of vision. So invariably, patients who are hyperopes have cornea curvatures of 40, 41, and that's a good rule of thumb. If you run into a rare myope who has keratometry of 40 to 41, then in my opinion, that's a genetic mixture of myopic genes and hyperopic genes. But in any case, that's pretty much my experience of what I practice now. And I think this is what most people practice in Europe and the US. They do hyperopia of up to 3 diopters. Although in the US, many colleagues and many friends of mine go directly to multifocal lenses for or trifocal lenses for, let's say, a 50-year-old hyperope that's even 2 diopters hyperopic, because that way they'll be able to deal with both hyperopia, presbyopia, and mid-range vision. I'm personally not a big fan of that, but I know that many people are, and that's almost a standard of care for a large portion of clinicians in the US and outside the US.
Thank you. So I'm sort of asking this for a personal reason. My fiance is like +6 in one eye and +4.5 in the other, and she's 30 years old. So is there anything that she wears contacts, but is there anything that that any sort of refractive surgery that's offerable?
Well, that's the toughest case possible. That's the toughest case possible, because you're in your 30s. You're looking at, considering even cataract 30 years down the line. You know, depending on the cornea curvature, I would consider LASIK as an option. The one tricky thing with 30-year-old hyperopes is that the true hyperopia may not be 6 diopters, may be 8.
Mm-hmm.
So if she, for instance, is a real 8 diopter hyperope, then I would jump directly into doing a lens exchange there. That's the only sensible for a +8 hyperope, in my opinion, option, because you're reducing the chance of future angle closure. As I said, especially in a +6, you have to be very careful with the angles of the patient.
Yeah,
Unfortunately, most clinicians, in most busy practices, the ophthalmologist sees the patient dilated, and with through the cycloplegia, the lens move backwards, and they cannot get a feel of what the real functioning depth of the chamber is. But if you cycloplege your fiancée and she continues to love you as much and remain your fiancée after cycloplegia, which I certainly hope so, and you pick up, you know, higher levels of hyperopia, I would certainly either wait to do a lens-based procedure or look more towards that direction. But for +4, and if that was a real +4 with cycloplegia and a 30-year-old, I'd feel comfortable doing LASIK.
Okay, thank you.
Sure.